I'm Rachael Piltch-Loeb. I'm a doctoral student at NYU, and David Abramson will be here in this session. But like any good sort of evolving response, we've also been able to expand our panel, and we're really excited to have with us Robert Van Pelt from New York City's Department of Health and Mental Hygiene, and also Joshua Epstein here from Johns Hopkins University. And I'll let each of them introduce themselves to you when they come to give their presentation. But we're really going to focus more broadly than just what's in your program, though that will be the focus of my presentation, more generally on using data to understand the Zika outbreak and how that has happened a little bit, how we're continuing to think about it, and then hopefully we can have a discussion about perhaps how it can be done even more effectively. As I mentioned, I'm Rachael Piltch-Loeb. I'll be giving the first presentation here. I'll also sort of be moderating the discussion, and I apologize to any of you who get sick of my voice by the end. But my presentation is going to focus on the U.S. public's perception of Zika risk, specifically around their awareness, their knowledge, and their receptivity to specific public health interventions. So the outline of my presentation, first I'm going to talk to you a little bit about the process we went through to collect this data, because I think that's really important to understand, because it's going to give a lot of context and color to the results that we have. I'll talk to you about our research findings, of course, from 3 different data points along with sort of the same questions we've asked over time. And then finally, we'll discuss what the implications and the utility of that information may be. So first, our approach. We came up with a series of research questions when Zika sort of was first coming about. There was a lot of national attention to it in the winter of 2015 and in the beginning of 2016. And we had 4 research questions. This is myself and my colleague David Abramson, who I mentioned before, at NYU. We wanted to sort of see how risk salience may change over time and whether or not that related to what we actually knew about Zika, or if it was sort of independent of the scientific information that was out there. We wanted to see how policy and social relationships were influencing risk. We wanted to describe the groups that sort of felt they were most at risk. And ultimately, we wanted to have information on what public health interventions people were receptive to. Because if we're going to need people to make behavioral changes and take preventive measures to help control this outbreak, we kind of need to understand a little bit better what it is they are receptive to. So the primary data I'm going to be talking to you today was collected in a nationally representative phone survey conducted by Social Science Research Shop. And we also did an oversample of women of childbearing age, particularly in the Gulf Coast region, which is what was predicted to be the most high-risk region. So we did Texas, Florida, Alabama, and Mississippi. This data was part of a national survey that they do regularly. So their data is also what it can inform polls sometimes. Other research shops are using it, companies. So it's for market research and now for some public health research too. This data was collected 3 different times in 2017. And I'll show you the timeline in a minute, so we have 3 time points to discuss with you today. And we plan to repeat some of the same questions after sort of mosquito season has peaked in 2018, so we can sort of see again how the things we found thus far, how they've continued to evolve. What does that chronology look like? So in February, this project that I'm talking to you about was ultimately funded by the National Science Foundation in a rapid research grant. February, we got in touch with NSF. By April, we had the grant moving, and we were in the field pretty quickly afterwards. So April, July, and October are the beginnings of each of the waves of data we collected, and from that initial date, we were in the field for about 6 weeks. So that's what those time periods were spanning. I should also mention that in our research group, we have also followed a panel of women of childbearing age since a similar time point, kind of starting last summer, and we're still in touch with them now. We've also done qualitative interviews with them, and for those of you who are interested in that, unfortunately, that won't be the focus of today's presentation, but we will be looking forward to sharing some of the information we found in that project as well. So we're just focusing here on what is the left hand of the slide for you, which is the NSF study of broadly U.S. Zika risk perception and intervention receptivity. Approximately, we have 3,800-ish, an N of 3,800 over these 3 different time periods, again, all weighted up to the U.S. population level. what does our timeline look like in the context of some Zika events that were happening? A lot of you are probably very familiar with the Zika outbreak if you've chosen to come to this session, but how did our data collection time points match up in the beginning with some of those sort of key events? So we were in the field after there had been first reported cases of sexually transmitted Zika in the United States. We sort of were up in New York, so we were hearing a lot in June between our data collection points about microcephalic babies being born in New Jersey, and that was sort of all over the front page for us. So we included that in our timeline, and of course then we also wanted to make note that between waves 2 and 3, the Rio Olympics happened, and we thought perhaps that would shift some attitudes. Because we are researchers, we have to have a sort of framework that we think about when we think about why we're approaching this question the way that we are. And I think it's actually helpful for everyone to think about why are we interested in this? What do we think risk or knowledge about a disease or who you talk to has to do with whether or not you're going to be receptive to an intervention. So this is an adaptation of the protective action decision-making model, which has typically been used to understand evacuation behaviors for hurricanes or other sort of natural disaster events. They're much less so in terms of a public health context. But because Zika has a lot to do with kind of your receptivity to take an action in the same way whether or not you would evacuate would, we kind of adopted that framework and have sort of seen some utility in doing that. So these kind of are key pieces that we're going to be putting into our models to understand ultimately what's in that bottom corner, which is our outcome of interest, whether or not people are receptive to public health interventions, and ultimately if they would make a behavior change if they were concerned about Zika. So we believe, and this model sort of suggests, that risk salience, sort of your personal threat, how at risk you think you are, whether you think your community's at risk, your knowledge of the disease, in this case Zika, those are going to be strong influencers of your receptivity to interventions. But that's not the whole story, of course. So there are factors that are going to influence whether or not you're knowledgeable and whether or not you feel at risk, and ultimately also whether or not you're willing to adopt an intervention. And those are sort of cues. So what are you hearing in the press? What does your social network say? Are you on social media and hearing about Zika? And so we asked questions about these cues as well so that we could think about whether or not these were having direct effects on the outcomes of interest. And finally, there's stuff about you, or the collective you, that likely also influences whether or not you are receptive to give an intervention. So those are things like your sociodemographics, gender, age, race, income, education. Your political ideology. Public health issues can become politicized, and they require sort of funding from Congress, so political ideology certainly could matter. How confident you are in your government, in your local government, to be able to take action, and that can be shaped from a variety of different factors, but that has been found previously to relate to whether or not you're willing to take government sort of encouraged action. Self-efficacy is kind of how able you feel you are, how much you feel able to do something, So it's kind of an inherent trait. And it can interact with how you have interacted with the medical system before. Your access to healthcare, so you're probably not going to take a healthcare-based intervention if you can't get healthcare in the first place. And finally, just your decision-making style. I know there's more inherent or innate trait that people exhibit, and they have patterns of behavior. So there was different sort of individual factors we also examined, and in the interest of complication and not having this full model operationalized structurally, we're going to be talking about these kind of just as individual predictors. So for those of you who are familiar with just regression analysis, we are just solely saying, are these characteristics associated with the likelihood of taking an action when we get later on to the analyses. In this fancy sort of drawn out model, this is far more complicated and dynamic, but it's not where we're at yet in terms of our results in sort of modeling these pathways. So I've shown you the model. What were the questions we actually asked? Well, we asked, how did we ask about risk? We straight up asked, do you think you or your family could be directly affected by Zika? Do you think your community is at risk or could be affected by the Zika virus? what did we ask about? What were some of our outcomes of interest? And these are some examples. So I'm going to talk to you about 6 different potential interventions, some data analysis I was doing while here, hearing what folks were actually doing in the field. We actually asked about outdoor spraying and larvicide behavior and travel, willingness to change travel plans, so I incorporated those as well. But this is what we asked about: indoor spraying, delaying pregnancy, and the availability of abortion services. So we asked about whether, in terms of pregnancy, if they themselves would be likely to delay getting pregnant, perhaps for a year or more because of public health warnings about Zika. For indoor spraying, whether they agree with targeted mosquito spraying on personal properties. And then certainly with abortion services, should the government make sure that services are available for women who wish to terminate their pregnancy as a result? So these were direct in terms of what we were getting at, if people were sort of receptive to them. And like I said, I'll talk to you about some additional interventions as well. How did we ask about awareness and knowledge? So we had thought that there were 3 sort of key things about Zika that people, if they were knowledgeable about it, would understand. 1, a baby could be born with birth defects. 2, it can be sexually transmitted. And 3, that you can have it and be asymptomatic. Sort of some of the key things about Zika that make it a little complicated. And for awareness, we just asked if they've heard about Zika. And then finally, in terms of our cues, we asked about their sources of information. Now, this isn't a perfect measurement of cues. We have some additional questions, but when you're seeing the data that I'm going to present to you now, this is what we've drawn from. Have you gotten information about the Zika virus from these sources, and which is your primary source of information for information about the Zika virus? So, enough talking about the measures. Let's actually look at some of the results. And first, we'll start with awareness, and then and knowledge, and then we'll go into intervention receptivity. So, here are 3 waves of data. You'll see I put the dates there, and p-values indicate whether or not there's a statistically significant difference between each of those waves of data. So, did something change? Is essentially what that's telling you. You can see the public was more familiar with the term Zika as time went on, which is good. You know, we go from 77.9% to close to 90%. But some of those knowledge variables actually declined if we break it out. Their knowledge that Zika was related to birth defects or of asymptomatic infection, those significantly declined over time, and perhaps that's because less information-based media or data was coming out, or people stopped reading articles about Zika besides seeing microcephalic children on the cover of the New York Times. When you sort of aggregate all of those knowledge variables up to this kind of knowledge all, so that's saying somebody who knew all these things about Zika versus somebody who didn't know all of these things, the aggregate didn't change statistically over time, but it's a pretty low percentage. Overall, the actual fundamentals about Zika at their highest only got to 38.7% of the population, and sort of as of October and November, we're only sort of at 33.9% of the population. So regressions are always challenging to show, but I am going to show you a regression of what were the strongest actual predictors when we control for those moderators, those socio-demographic factors, those sources of information that predicted if someone was aware of Zika. Just hearing that term, are you familiar with Zika? So obviously, the change time, the wave variables indicate that something changed over time. People who were in the higher income categories were more likely, I should back up and say, the numbers you're seeing here, or here, those are odds ratios. So below 1 indicates that they are less likely to have heard about it, and above 1 indicates they are more likely. So somebody who we talked to at time point 2 is 2 times more likely to have been aware of Zika. That's how you can make sense of those numbers if you're sort of less, if this looks like craziness to you. Females were more likely to be aware. Those who were over 65 were more likely to be aware. Those who identified as politically independent were less likely to be aware. And finally, those who are getting their primary source of information from traditional news media were far more likely to be aware in comparison to those getting their information from social media or other sources. I think that I should note also, you see that significantly low odds ratio for physicians in terms of awareness. There's a very few people who identify physician as their primary source of information for Zika, so we think it's a little bit of an outlier in terms of what happened. Who's knowledgeable? So this is that all-encompassing knowledge variable that we were showing you at time 3 is 33.7% of the population that was knowledgeable. Females were more knowledgeable, those who are in the highest income category, Democrats, and those who got information or identified the government as their primary source of information. So that's, yes, maybe a moderate win. Yes?
So all these odds ratios you're showing, are they all significant?
I'm only showing you significant odds ratios. Everything that you see as a variable here was in the model, but only the significant odds ratios have been presented here too.
Just one more question. The previous slide, that 2 for waves 1 and 2 and 3. So I assume the reference category was wave 1.
That's correct. So thank you for clarifying or asking that. The reference category has either been shown here in parentheses, or for primary source of information, we had social media, and for waves, we had wave 1. Thank you. Okay, so we're back to knowledge. I sort of just described this to you, but it looks different from awareness. So there's something distinct between just hearing about Zika and actually knowing about Zika. All right, so how does this look in terms of interventions? I should mention that when we're talking about intervention receptivity, the questions were only asked of those who are aware of Zika. So now, the awareness, we've described it, but we're gonna move forward just with sort of how does knowledge relate to intervention receptivity rather than awareness, because these questions were only asked of those who are aware. So, here we go. Again, you have our 3 time points. You have wave 1, wave 2, and wave 3. What's bolded and has a p-value below 0.05 was significant. So the intervention receptivities that changed over time were willingness to delay pregnancy, willingness to change travel plans, and whether or not they would use larvicide on their properties or accept the use of larvicide on their properties. In all cases, they significantly went down over time, which perhaps isn't so surprising. Again, perhaps the concern level changed among individuals. There was less information coming out that would suggest that they shouldn't. Mosquito season was over by October and November, so if they had concerns in their own area, those concerns were sort of no longer as much of an issue to them. Though the travel plan is certainly interesting and potentially challenging for those who we still need to be encouraging to not travel to areas with Zika. So like I mentioned, these are the 6 interventions that I'm going to show you regressions about in terms of what predicted whether or not people were receptive to that intervention. And if you like the sort of model slides I just showed you, you have 6 more to look at, so bear with me here. When we look at demographic factors, when we look at cues, when we look at confidence in government and knowledge and personal risk and time, looking at all of that together, what predicts whether or not someone would delay pregnancy? And it is age, which shouldn't be too surprising to anybody. I would think those who are 46 to 64 or over 65 certainly don't want to be thinking about pregnancy. They probably want children out of their house as much as possible. Race, those who are Hispanic were far more likely to delay pregnancy. I should also mention that 5 to 10% of each survey was conducted in Spanish, so we did have Spanish speakers incorporated into our sample. And knowledge. So if you were knowledgeable about Zika, you were far more likely, or 40% more likely, to delay pregnancy. Changing time didn't hold as a predictive factor. Personal risk was not related. Confidence in government and cues not related when we look at this model together. Travel plans look different. So women were more likely to indicate that they would change travel plans, and those who lived in the Gulf region. So the reference category is North, Gulf would be in the other region that we looked at because we had that oversample in the Gulf. But none of the other factors made a difference. Indoor spraying, and we're going to talk about the 3 sort of environmental interventions: indoor spraying, larvicide, and outdoor spraying, and what that looked like. So women were less likely than men to support indoor spraying. Those who were older were less likely again. Those sort of in the middle education bracket between high school and college were less likely. Hispanics were more supportive once again. And I want you to pay attention because this confidence in government line for the next 3 interventions is going to be significant. So for all environmental factors, those who felt confident in their local government were more likely to support an environmental intervention. And knowledge also shows up here. When we look at larvicide, Hispanics and those who are confident in government. And when we look at outdoor spraying, we see a difference by income, we see a difference by age, we see a difference by region, and we thought maybe those in the Gulf were more familiar with outdoor spraying, which is why they would be more receptive. And again, confidence in government. So I think that's an important note, and we'll get to some of the implications when we think about what government can do and why it matters in terms of interventions for something like Zika. And finally, the support for abortion funding. Again, knowledge comes back. Political ideology matters, which shouldn't be surprising to anybody. Those who are in the middle 2 income brackets we assessed were less likely to support it. Perhaps it's how they perceive government funding to be being used. Those who are 30 to 45 were less likely, and those in the Gulf less likely. So let's sort of try and wrap this a little bit. When we try and talk about it, myself and my colleague, we think of some of these behavioral interventions, delaying pregnancy and travel a little bit, but delaying pregnancy being a serious behavioral decision that you or your partner would have to make. Knowledge is a strong driver beyond your demographics, and so if we're interested in that, we could be targeting and trying to increase knowledge among those who are thinking about among women of childbearing age. Environmental, if we think about spraying and larvicide, confidence in government is a really strong and enduring predictor. And if we think about abortion access, we're back to knowledge, but it's clearly a more complicated picture as all those demographic factors kind of work really enduring. So I like to say it's sort of different strokes for different interventions. We, or public health and sort of those who are involved in this response, risk communicators, we need to be thinking about what intervention are we actually trying to promote, because it will change, or it should change, how we're trying to interact with the public and what we're trying to tell them. If we're trying to move forward with environmental-based strategies, then that local government, that interaction, getting out there, having confidence in your local government matters a lot, and that should be a sort of a focus in messaging and in attention. If we're trying to encourage women to delay pregnancy because we're concerned about Zika, we really need to be getting the right information out there. So I think that we need to be thinking about this in a more nuanced way, and I'm sure many of you are, but I think that these results certainly support that. Region, income, ethnicity, and politics matter, which is not surprising to anybody, but these sort of enduring issues, these vulnerabilities, they come up in Zika, and they continue to sort of be things that we need to think about as we target interventions. I would like to point out that risk perception is not what drove any of these regressions, or any of these analyses. So it's about knowledge, it's about your socio-demographics, and it's about your trust in government. Much less so, we don't need to necessarily be driving people to identify as feeling at risk for Zika as much as we can be driving them towards these sort of other paths. Why do I think this data I'm presenting to you is from the general population? I think that matters, and I think that matters because women of childbearing age or people in communities, they're affected by those around them. So if you have a conversation with your mom, you're a woman of childbearing age, you're thinking about whether or not you should change travel or delay pregnancy, if you want to talk to your mom about that, you are influenced by what she's going to tell you. And she may be in that 46 to 64-year-old age group or that 65 plus age group. So those interactions, they matter. I'm doing a related project, doing qualitative interviews with women who identify as high risk for Zika as part of that RWJ project, as well as their interactions with clinicians. And time and again, they tell me about who they talked to about Zika and how that influenced what they were going to do. So I think that when we think about why population data matters, it's because the people we may want to be targeting the most for our interventions talk to and live with and are surrounded by those in this general population. So we need to be thinking about how everyone is thinking about Zika. The awareness and the knowledge charts that I showed you, there is potentially concern of Zika fatigue for those who think that there may be a pop this summer, and that's something that everyone should be aware of and thinking about as we need to get more information out there. Our future analyses, we're going to think about additional moderators that we didn't show you today that we have in our data. Some of those individual level efficacy things I mentioned. We're going to focus on women of childbearing age to do subgroup analyses because we can, and I understand that for a lot of risk communicators and practitioners, that's really important. Sort of anecdotally, when we were first, just looking through the data, we think there's some real differences between what younger and older women of childbearing age would be receptive to, because pregnancy may be becoming increasing, or having a child is increasingly important. Perhaps as you're an older woman of childbearing age, we need to think about how to speak with that demographic. We're going to look at some external data to think about how specific media messages were affecting people's risk perception and receptivity to intervention. I sort of spoiled 4 and 5, but those qualitative interviews that I was just mentioning, we're going to look at information seeking and sharing and how our qualitative analyses can sort of further paint a more specific and nuanced picture of what we're finding about interactions with providers, information seeking and sharing. So the next 2 presenters are going to touch on some of these things, which is why we think that this data can be useful. Not only to be speaking with you all about it and to sort of provide this level of color, but to think about how what we've come up with in our data can support sort of agent-based models of, and Josh will speak to that. We can sort of establish this baseline of intervention receptivity to understand whether or not when we do something, it affects how people are, how they are not receptive to an intervention. So did something we do change this level of what we're seeing? We can sort of refine our ability to measure, knowledge, attitude, behavior of the population, and think about how to do this even more rapidly than we were able to better inform message risk communication. And we can think about how to do this in smaller areas, and where we are working with New York City's Department of Health to think about how we can talk to providers about some of these same questions. So again, thinking about this on a smaller scale, how it can be more targeted and useful when you're in given jurisdictions. So I will pause there. I can take any clarifying questions now, or we can sort of all speak together at the end. Yes?
A quick question about I just want to push back a little bit on the perceptions don't matter. I was wondering if there's a bivariate correlation there, in that it's possible that what you found is that risk perceptions could impact, intentions and receptivity, but it's just that it's mediated by these other social and cultural economic factors.
Yeah, no, that's a great question. So these are overgeneralizations, and there's nuance in everything that's there. We looked, and I didn't present it to you today, but just to sort of add crosstabs or correlations between risk perception at the individual level and at the community level. And it shows up slightly if we're thinking about delaying pregnancy, but it's like a 1.2 odds ratio, sorry for those who this is like too technical. So it's a pretty small relationship, but it's sort of right on that cusp of significance. Your confidence interval is really approaching 1. So, and it didn't have a direct effect on any of the other interventions. And then when you see the models, it's not surprising that it drops out. But I do think you have an important point that these are not just all direct pathways, and we need to model this in a structural way so that we think about what are the strongest effects. But that's certainly for sort of the next steps. Yes, in the back. Thank you. It's big.
It's a small room. I don't know if you said this, but do you plan to take into account any religious or cultural beliefs in delaying pregnancy, because that could affect use of contraceptives?
Definitely.
So
we ask, it's an important, in that the women of childbearing age, the questions that are international sample are designed for everyone. So we do have religion data on what their religion is, which is not currently in our model and perhaps should be added. In our panel of women of childbearing age, we ask about their attitudes towards contraceptive use. So again, that data wasn't here, but it's something that we can look at on a much smaller scale because it's directly relevant perhaps to that population, but I understand also that they're influenced by those around them, like we've said, in terms of their attitudes.
If you're going to start tailoring, help people decide how to tailor interventions or develop public health messaging, a lot of those things come into play with
certainly. Yeah, absolutely. And I think that, one of the takeaways here is these are giving you broad swaths of what's available and what's out there in the most general terms that we can. I think that there are a lot of ways it can be improved, and certainly like we could put probably 20 more variables into these